Yeah, thank you.
You're
Hello,
audible.
everyone. Yeah, I'm Lasanthi Perera. I'm a general physician from Sri Lanka. Today, my presentation is on post-COVID syndrome among COVID-19 patients who were treated at National Hospital Kandy, Sri Lanka. So, long-term consequences after SARS-CoV-2 infection are becoming important burden to the societies. According to National Institute of Health and Care Excellence guidelines, post-COVID-19 syndrome refers to persistent symptoms beyond 12 weeks of infection without an alternative diagnosis. This study has been carried out to determine the prevalence, risk factors, symptomatology, quality of life impacts associated with post-COVID syndrome among patients attending post-COVID clinics at National Hospital Kandy, Sri Lanka. So the early public health responses were targeted on minimizing the acute issues of COVID-19. Latest literature shows that SARS-CoV-2 infection also can be complicated with long-term physical and mental health issues. There are more than 160 million confirmed cases of COVID-19 worldwide, and it had caused over 3 million deaths in the past. Most people with COVID-19 develop mild to moderate illness, while nearly 10% to 15% can develop severe disease, and 5% can become critically ill, according to the literature. The average recovery time from COVID-19 is 2 to 3 weeks, depending on the symptom severity. However, 1 in 5 people, regardless of the severity of the acute infection, may exhibit symptoms for 5 weeks or more, while 1 in 10 may have symptoms lasting 12 weeks or more. A cohort study done in Bangladesh found that there were strong association between post-COVID-19 syndrome and female gender, prolonged recovery, persistent positivity on RT-PCR after 14 days of initial test, and moderate or severe illness at presentation. The COVID-19 symptoms continue nearly for 11.5 plus or minus 5.7 days. However, during the post-discharge follow-up, significant number of patients were found to be unwell. In United Kingdom, a smartphone-based application revealed persistent COVID-19 symptoms in approximately 10% of the patients after 3 weeks of the disease onset. In some patients, the symptoms persisted for months. This fatigue and dyspnea were the most common symptoms after acute COVID-19. It is mostly associated with significant reduction in coping up with pre-illness occupation, learning abilities, social activities, and activities of daily living that persisted for more than 6 months. Patients with long COVID get number of physical and mental health problems. These patients need multidisciplinary care involving long-term follow-up of symptoms to recognize common complications and physical rehabilitation, mental health, and social service input. Well-structured healthcare system could be in place to ensure efficient and effective response to their future healthcare needs. So treatment of COVID-19 does not conclude at hospital discharge. A significant proportion of patients experience persistent symptoms that impact their daily activities and well-being. It is important for the healthcare teams and hospitals to identify the requirements to set up special clinics for COVID-19 patients where doctors from multidisciplinary specialties and allied health teams can provide comprehensive care. Identification of prevalence, risk factors, which can lead to post-COVID syndrome, will help in early reassessment of these patients in post-COVID clinics, preventing long-term complications. Counseling and rehabilitation services could be arranged if quality of life is affected in patients after COVID-19 illness. Therefore, our study aimed to determine the prevalence, risk factors, symptomatology, and quality of life associated with post-COVID syndrome. So our study was a descriptive cross-sectional study. It was conducted among post-COVID-19 patients who were treated at post-COVID-19 clinic at National Hospital Kandy, Sri Lanka. It was done as a simple random sampling method. Data were collected by obtaining approval from the Ethical Review Committee. The data were collected using interviewer-administered questionnaire and analyzed using SPSS 20. So these were our inclusion criteria. We included moderate to severe COVID pneumonia patients with major complications and uncontrolled comorbidities who have been treated as inward COVID patients at National Hospital Kandy. COVID-19 patients who have been treated at intermediate care centers who needed further assessment due to ongoing symptoms, and patients were above 18 years old. And we excluded patients with psychiatric problems because they lack capacity to give a good history, and we excluded critically ill patients who were in the ICU because they can develop post-intensive care syndrome. So if we talk about the results, this is demography. Out of our 150 patients who had symptomatic COVID-19 infection, 79 were females, accounting to 53%. 71 were males, accounting to 47%. Mean age of our group was 52 years, minimum age was 19 years, and maximum age was 85 years. And out of our 150 COVID-19 patients, 96 were completely vaccinated, accounting for 64%. And 44 patients were incompletely vaccinated, and 10 patients were non-vaccinated. Most of our patients with COVID presented with fever, accounting to 56%, and cough, accounting for 53%, and sore throat, accounting to 49%. And others presented with shortness of breath and headache, rash, diarrhea, and myalgia. So if we talk about the severity of our patients with COVID-19, 94 patients were having mild COVID initially, and 29 patients had moderate COVID, and 24 patients had severe COVID infections. So we calculated the prevalence in our study. It was 18%. So these were the common post-COVID symptoms we found out during our study. Most post-COVID patients presented with cardiac symptoms, that is chest pain. 79 of our patients had chest pain, accounting for 52%. And others mostly had respiratory symptoms, cough. So 70 of our patients had cough, and others in our study group had numbness and weakness of the body, myalgia, diarrhea and reflux symptoms, ENT and eye signs, and symptoms of depression. So these were the comorbidities we found out in our post-COVID patients. Most post-COVID patients had comorbidities such as ischemic heart disease. Actually, 19 patients had ischemic heart disease in the past, accounting for 12%. And 39 of our patients had hypertension, accounting for 26%. And 40 of our patients had diabetes in the past, accounting for 26.7%. And 17 patients had bronchial asthma in the past, accounting for 11.3%. And 3 of our patients had history of CKD, and 1 patient had history of psychiatric illness. So we analyzed the effect of this post-COVID syndrome on quality of life of our patients. The quality of life of post-COVID patients was assessed by using this validated questionnaire, EQ5D3L. The quality of life was adversely affected by post-COVID syndrome in 125 of our patients, accounting for 83.3%. And 22 of our patients lost their occupation due to this post-COVID syndrome. And 54 of our patients needed rehospitalization due to ongoing post-COVID symptoms, which required further investigation. So these were the common we found out in our post-COVID syndrome patients. 27 patients had chronic fatigue syndrome, which accounting for 18%, and 17 of our patients developed ischemic heart disease following post-COVID syndrome, accounting for 11.3%, and 21 of them had interstitial lung disease, and 10 of our patients had hyperglycemia. So according to a study done in UK by Ibushe et al., prevalence data showed that fatigue, shortness of breath, muscle pain, joint pain, and headache, cough, chest pain, altered smell, and altered taste, and diarrhea were the 10 most reported symptoms. In our study, chest pain, cough, numbness, and weakness of body and GI symptoms were the common among post-COVID patients. A cohort study done in Bangladesh found that fever, cough, respiratory distress, and lethargy were positively associated with development of post-COVID-19 syndrome, but there was negative association between sore throat and post-COVID syndrome. In our study, fever, cough, and sore throat, all three were positively associated with development of post-COVID syndrome. In our study, chronic fatigue syndrome, ischemic heart disease, and interstitial lung disease and hyperglycemia were among the commonly identified long-term complications of post-COVID syndrome. According to a study done in United States by Tenford et al. And in Canada by Modowski et al., immune system changes due to viral illnesses might be the reason for this fatigue, possibly of cardiovascular abnormalities occurring in patients with long COVID was supported by other studies as well. In 40% of COVID-19 patients presented with pericarditis and myocarditis, more than 70 days after infection, according to literature. In another study done in China by Zhao et al., lung function abnormalities were detected in approximately a quarter of patients at 3 months after hospital discharge. The commonest lung function abnormalities was change in DLCO. Of the patients with lung function abnormalities, 12 also had radiological changes, including evidence of lung fibrosis. Quality of life of post-COVID patients was assessed by validated questionnaire EQ-5D3L in our study. So quality of life was adversely affected by post-COVID syndrome in 125 significant amount of patients in our study, and 22 of them lost their job following post-COVID syndrome. There were few other studies found in literature with similar findings. Comparison of this EQ-5D3L index score in a study done in Spain by Taboada and al. Before acute COVID infection and 6 months after COVID infection was done, and they found out a significant difference in quality of life with a p-value of 0.001. A study done in Michigan, US, found 195 patients who were employed before hospitalization for COVID-19. 40% were unable to return to work within 8 weeks of discharge due to ongoing health problems or loss of their job. Of those who returned to work, a quarter needed to reduce their work hours or alter their duties for health reasons. So these patients with COVID-19 after recovery from acute illness need long-term follow-up for identification and management of their post-COVID complications. An effective rehabilitation program is therefore needed for such patients during hospitalization as well as at discharge. Therefore, many countries have implemented specialized clinics to address their increasing healthcare demands and improve quality of life. There were a couple of limitations in our study. The research was carried out at a single center due to limited resources and time constraints. Had it been conducted across multiple centers, it could have provided a broader understanding of this disease. Additionally, if the participants had been followed up for several years instead of just months, the outcome might have differed, offering better insight into the duration of recovery from this post-COVID syndrome. So these were my conclusions and recommendations. COVID-19 patients need long-term follow-up to detect development of post-COVID syndrome. Post-COVID syndrome can be seen frequently in patients with comorbidities like ischemic heart disease, diabetes, hypertension, and bronchial asthma. And this post-COVID syndrome can result in long-term sequelae like chronic fatigue syndrome and interstitial lung disease. The quality of life gets adversely affected by post-COVID syndrome, and some people could not cope with even their daily activities. Even this can progress to a point where they lose their job. So comprehensive rehabilitation services and special post-COVID clinics, like in other countries, would have been beneficial to overcome these issues. So I would like to acknowledge the participants of this study and the support we got from Teaching Hospital Kandy, Sri Lanka. There were no conflicts of interest, and it was a self-funded project. So these were my references. Thank you very much.